Good afternoon. It's my pleasure covering the topic on gender-sensitive issues and starting off with my conflict of interests declaration. So I've been involved working with different pharmaceutical companies, but none of the companies has been involved to any of the results of my presentation. If we talk about gender, we actually need to cover also sex. Sex is actually defining the biological topic, and gender includes the psychosocial aspects. And I'm pretty much convinced all of the countries you are coming from in the audience have signed the ratification of gender mainstreaming, which actually means that all of these aspects should have been integrated since 1995, but this is where the ratification was, in all areas of the society. Unfortunately, we know this is hardly in any country done so far, especially not in regard to earning money for the same job. But before I go to the addiction problem, I think it's very, very important in general to emphasize that there are sex differences in the structural connectome of the human brain. So not talking about people who suffer on a disorder, and even in this case on a psychiatric disorder, there are major differences in the connectivity between the brains. The women actually, or let's start with the male brains are structured to facilitate intrahemispheric cortical connectivities. Also the opposite is the case in the cerebellum. You find here the blue spot. And the women, female brains displayed higher interhemispheric connectivity, which actually shows clinically or phenotypically some differences, whereas males' behavior are usually to be more on the point, being better in kind of logical conclusion drawing, and the women, due to the interhemispheric connectivity, are also integrating, for example, intuitive information in the reporting system. I think we all need to take into account how the situation in normal human brains is working. But coming to the substance use problem, the lifetime prevalence, these are data from a huge US study. They looked into gender, or more precise sex differences towards substance exposure. And the blue circle shows you that in any substances, it's pretty much male dominated. However, if you look into the lifetime prevalence of substance dependence, we find some gender differences. They found a significant higher prevalence of alcohol and cannabis dependence in males, whereas a significant higher amphetamine dependence in women. This is actually supported by another study I'm showing you later on. The phenomenon of the male-dominated problem of addiction is known. However, these are data from SAMHSA. The gap is narrowing down, and more women are coming into the field of any addiction. And in some of the addiction, for example, in nicotine addiction, actually women in some countries are leading the problem. If we talk about sex and gender differences in addiction, most of all, it's important to consider healthy individuals are not getting dependent on substances. So some differences in comorbidity are existing before becoming dependent, and other comorbidities are acquired by persons after they use substances. Marta is going to be in detail into the comorbidity issue, but just to highlight very briefly, all the affective disorder problems are much more common in females in relation to substance use. And for example, ADHD, where Dr. Wim van den Brink is going to go into detail, is much more common in boys, which might initiate, if it's not properly diagnosed and treated, a substance use problem. In regard to behavior, we find more externalizing factors in the males, whereas internalizing behavior in women. Very often, drug use is initiated by males to women, And what was pointed out already by Luisa, the mortality, the high-risk population are the males. In alcohol dependence, we have a phenomenon which has been confirmed and confirmed and confirmed. The consequences are more severe and more rapid progressing in females. They develop higher alcohol concentration after equivalent amount of alcohol. They show a faster progression of the alcohol dependence. They heighten susceptibility to the organ damage, and they have a higher sensitivity to alcohol-induced brain damage. This is a phenomenon what is also known as telescoping phenomenon. Women are less likely to have received treatment for alcohol dependence. This might be related to many, many aspects, which is shared by the illegal substance dependence. Like very often, it's also related to the stigma in treatment facilities. Again, the comorbidity is higher in women. There is no gender differences in anxiety prevalence in alcohol-dependent person. However, the severity is higher in women. And the antisocial personality pattern shows higher for males. That the issue of gender and sex is important has been a topic in two prominent journals, one in Nature, putting gender on the agenda, saying that medicine as it's currently applied to women is less evidence-based than that being applied to men. And also in Science, pointing out gender in the pharmacy, does it matter? And there are some medication, actually the best invested medication is the heart medication, looking into gender differences. Some opioids, more looking into the different action of opioids in regard to the GABA receptor opioids ability. And one, actually the only nice study is a prospective study from Susan Kornstein, looking in the different responses of serotonin reuptake inhibitors and tricyclics between the both sexes. There's actually also one wonderful study by Tamar, Wim van den Brink's wife. She did an evaluation, a respective evaluation, and could not find significant influences of gender. Well, if we take medication, John Strang pointed out to the issues of pharmacokinetics and pharmacodynamics, what is important, what amount of medication is coming to the final target. And what seems to be very hormone sensitive are the drug transporters and drug metabolizing enzymes. They are modulated by sex hormones, very much by estrogen. And that's a difference towards the drug metabolization in males. Like women clear some cytochrome 3A4 enzyme drugs faster than men, and which might be an example that methadone, when given in pregnancy and the pregnancy is proceeding like to the third trimester, there is an increase required on the methadone dose, or even a necessity to split the doses. There's also something more complicated in the female body. It's not, if you in comparison to the male body of having the decreasing testosterone, the women's body has the different hormones in the menstrual cycle. Then quite some women are taking oral contraceptives. We do know this, or we would be happy in our, for example, maintained female population, in order to have a family planning. On the same time, we are not too happy using oral contraception because the majority of them is heavily smoking. But of course, there is a lack of studies if oral contraceptives are on board. And as I pointed out, pregnancy and also regarding the menopause. If women are passing the menopause, their similarity to certain drugs responses is much more similar. Methadone, an example, like I pointed out, the heart medication is best investigated. But methadone, regard to the QT elongation, is also investigated. And women per se have a longer QT distance, and which can be elongated if they are administered on high doses of methadone, which again in pregnancy it's important to pay special attention. And if we talk about the high affective disorder comorbidity loading in the women, and if we treat them, very often also neuroleptics are added to this medication. So a special focus needs to be given on this interaction when women are on methadone. I just want to point out to this one issue in regard to opioid sensitivity, the differences between the genders. It's a pretty constant research result that women experience more severe post-operative pain and require higher morphine doses. This has been replicated in experimental designs. Interestingly, after the menopause, both of the sexes are getting closer in their sensitivity. Why I'm pointing this out? We have a growing population being on opioid maintenance treatment. And for example, this is one publication of our research group. We found that in a prospective trial that following cesarean delivery, opioid maintained women either on methadone and buprenorphine received significant less opioid analgesics. And this is a major problem because to the non-educated population in the medical doctors, they think, oh, they're already on high dose on opioids. They do not need more medication, which is pretty painful, as delivery per se is going along with a lot of pain, and if you undertreat them, it's just a disaster. And if you forget to add the adequate pain treatment for maintained patients, you should not be surprised that they are relapsing in order to treat their pain. The importance to include gender in the substance abuse research has been historically focused, as I pointed out, on males. Women view substance use disorder more negatively and more concerned about social stigma than males. This is especially difficult of providing services when they are pregnant, but per se, treatment entry for women is less facilitated by social institutions, and I have been doing a lot of research in jail. Unfortunately, if you have substance-dependent women in jail, they are very disadvantaged because the delivery system is not readily prepared for them. What goes along if women have substance use disorders? One area, I'm pointing out at the end of my talk, is that very often they are in relationship with drug-abusing partners, which has a very disadvantaged result in regard to infectious diseases. And very often, like the women have more affective disorders, but the males show much higher criminal behavior. In the whole medical system, women are the more compliant population. However, not if it comes to substance use disorders. For women to be equally successful than male, finishing a standardized treatment and remain drug-free goes along with a multi-therapeutic treatment approach. And what seems to be also very important is at the first time treatment entry to have enough time for evaluating the situation of the woman. This is one study. The topic on gender and sex differences has been addressed over the last 15 years, and newer studies actually are integrating this. And this is just one example of a prospective study, the Naomi study, a study from Canada, looking into diacetyl morphine versus oral methadone, which a study set of prospective, randomized, controlled 12 months treatment retention. And the key findings were in this study, there was no significant difference between both of the genders. Another study, which actually looked in the secondary data analysis in sex differences, was the NIDA Clinical Trials Network. A study where they looked into the different effectiveness schedules of buprenorphine tapering schedules. And they found actually in this trial that the majority of both genders, male and females, tested positive. It's a tapering study for oxycodone and morphine. More women than men tested positive for amphetamines. This is a confirmative result what I've been showing in the first Prevalence study. And more males than women tested positive for methadone. So the newer randomized trials do take the gender sex issues into account. One aspect what has been highly neglected is the erectile dysfunction being maintained on opioids. And there is one study I briefly mentioned methadone versus buprenorphine compared to healthy controls, showing that under methadone maintenance, there is a lower plasma testosterone, higher rates of impaired libido, higher frequency of sexual dysfunctions, and the risk factors of erectile dysfunction maintenance treatment were related to methadone maintenance, not living with a partner, depression, homo or bisexuality, and a partner with history of drug abuse. No significant association was found with methadone or buprenorphine doses or treatment duration. So it's very important also addressing this, because you should not be surprised if these patients might be taking some stimulants in order to enhance their libido. If you talk problem women, more and more women, we had about 5% 1994, 15% 2004, receiving opioid maintenance, and they're older than 50 years. So you have to bear attention, because there's an overlapping area of clinical symptoms like sweating, insomnia, anxiety, depression, poor concentration, decreased libido, which might be related to the menopausal or perimenopausal area and not related to any other drug consumption. Bone density, it's also one of the areas we have to look into the longer patient being maintained. And this is a kind of a small scale study, but they found that the low bone mineral density was significantly associated with male gender, lower weight, more years of heavy alcohol abuse. So we actually, by having an aging population, we need to take into account clinical phenomena they are related to aging. In a cohort study comparing male and females in quote older methadone maintained patients, the mean year of 54, pointing out that male have significant more somatic problems like hypertension, diabetes, whereas women score higher in the affective mood disorders. And that's actually coming to the end, because this was also touched yesterday. And we all in the area are pretty much concerned about the HCV rate in our IV drug abusing population, which is ranging between, well, depending what kind of cohort you're taking, between 14 and 84%. Usually the states, like my state, is very much concerned about the high pricing of the new treatment. So it's very important to address, because the main risk group are our IV drug addicts. And we all know the treatment is very expensive, and we don't talk about a liver disease, we talk about an infectious disease. And we need to address this more often to have the addiction clinic integrated in this kind of treatment. And this was a study looking into a titled Higher Risk of Incident Hepatitis C Virus among young women who inject drugs compared with young men in association with sexual relationship. A very nice study design covering both risk factors and sexual behavior and IV drug abuse. And the question was, do men and women differ in respect to their risk behavior? Do these differences account for higher risk of HCV incidence? And this study, they looked into participants younger than 30 years, injecting drug users, HCV negative at the baselines. They had a structured assessment battery. They actually had a 2-year observation period, and finally 59% of the cohort was negative, and they looked into their risk behavior after 2 years. And what was the result? More than 100 new HCV infection, with women significantly higher incidence rate of new infection during the follow-up. Variables significantly were associated with the HCV injecting every day, injecting heroin. Interestingly, injecting heroin, I would have thought more psychoactive stimulants, then use of a syringe previously used by another injector, and having a steady relationship with a sex partner who is also a drug-abusing partner. Very often, it's even aggravated if the women are undergoing depression or anxiety disorders. And this is one of the studies. I don't know whether the slides are going to be made available. We did together with Dr. Torrance, SPI. And this is showing you nicely the situation if when depressed IV injecting women are about their risk behavior, injection behavior, and also related sexual behavior. And that's coming to the end. Being from Vienna, Sigmund Freud. If you have not been there in his house, it might be an idea to go there. The major question, which I am unable to answer despite my 30 years of studying the female soul: what wants a woman? I could say gender and sex-sensitive approaches may be the first steps in the direction of truly personalized medicine. What, after all, is more personal than sex? And the conclusion is treating him, treating her, both sex and gender matters. Thank you for your attention.